Welcome to the Fascia-Informed Therapist, the essential podcast for occupational therapy professionals looking to deepen their understanding of fascia's pivotal role in therapy and health. I'm your host, Amy Mayer, an experienced occupational therapist, practice owner, and dedicated educator. Here we'll dive into the fascinating world of fascia, exploring its significance in the human body and its critical influence on occupational therapy practice. Each episode will bring you cutting-edge insights, expert interviews, and practical strategies to help you confidently integrate the science of fascia into your therapeutic approach. Whether you're a seasoned practitioner or just starting out, our goal is to equip you with high-quality, evidence-based, and fascia-informed continuing education opportunities that will enhance your skills and benefit your clients. So join us as we unravel the complexities of fascia and transform the way you practice occupational therapy. All health and wellness practitioners are welcome. Let's learn, grow, and evolve together. Hi, this is Amy, and this is another edition of the Fascia-Informed Therapist. I'm really excited after yesterday. What happened yesterday was Caitlin and I went to Methodist, to their occupational therapy program, and taught a 3-hour lab on myofascial self-treatment. How they can use it for themselves and how they can apply these skills and these ideas to their future patients and clients. And it was super, super fun. Caitlin she took the lead on this, and she did an amazing job of putting together this lab. It was a version of what we've done for therapists, and it's also a version of what we have available online in our on-demand library. Now, what was super fun about it is these young, soon-to-be OTs were really engaged and really excited. And we know, Caitlin and I know, that when we start a lab like that with the participants down on the mat, feeling what it feels like, getting engaged in their own bodies and what myofascial techniques feel like when you apply them to yourselves, we know we're going to get their attention because it feels so good. We had some similar problems that we have when working with the public when we do this workshop, that people want to find that pain or tension and they just want to grind into it. They just want to roll as hard as they can, and the old no pain, no gain. And when we do these, whether it's the public or therapists or students, we're continually saying, okay, we're just rolling to explore through the tissues to see what's there. And then we're going to find them and we're going to gently press in. And we talk to them about what does that therapeutic sensation feel like when it's therapeutic versus maybe potentially damaging. And it was so interesting how we had a couple of athletes in the room, collegiate level athletes. I do not know if they were, I'm assuming Methodist doesn't have athletic programs, but I actually don't know. I'm assuming it was in their undergraduate programs, but they both talked about how different their bodies felt after the workshop and how absolutely amazed they were at how they felt. And one of the young women came up to me afterwards and said that, yeah, I had actually heard about fascia, but I was told it was only about my scars, and they would take this thing and they would rub it on me so hard. I'm assuming she was talking about instrument-assisted soft tissue mobilization. But she said they would go at it so hard and it was so painful. I just had to close my eyes and grit my teeth. So there are aggressive techniques out there that are intended to target the fascia. And I do use some instrument assisted, but I have definitely learned that that hard pushing and grinding is not effective. And a much lighter technique is going to net you more results, especially in the long run. What we ended up doing was we put them through a version of the workshop. They really enjoyed it. It was a lot of fun. And throughout the workshop, we were integrating a lot of fascia facts, and they had already had a lecture that Caitlin had done about some basic fascia science, and I was impressed with how much they remembered, and I could tell they remembered a lot because they were asking really amazing questions. So after we put them through the workshop and answered questions and had really great conversations about application, we put them into small groups and said, okay, pick a diagnosis, pick a problem, pick a case, between the 2 or 3 of you in the group, and talk about whether or not you would apply this, and then how you would apply it. How would you explain it to the client that you have identified in your case? And then we just went around the room and we had conversations about each one of those cases, and they did a really nice job thinking about who they would do it with. And we did, as part of the workshop too, show them lots and lots of adaptations for people who are in wheelchairs, for people who would just prefer to sit, how you could do it at the wall. And we actually had a young woman in there who was, I can't remember how many weeks along she was, but there were things that she couldn't do and we needed to adapt for her. And we had somebody else who had a lot of trouble in certain positions. And so we got to do a lot of adaptations on the fly and very genuine experience of adaptation for people. I got particularly excited, which I can tend to do in the classroom. And one of the groups said, well, we decided we were going to use this technique with someone with spasticity in their upper extremity after a stroke. And they did a really nice job of explaining why they would do it and how they would do it. And then I did what I do sometimes, and I said, okay, you guys, in my experience, there aren't any scientific articles supporting the use of myofascial techniques with spasticity. Should you do it? And they just sat there and looked at me, and I waited for a few beats, and then one of the students looked at me and said, well, why not? And I looked at him and I went, yes. And I literally went over there. He was sitting on the floor, and I squatted down and I gave that guy a hug. Because yes, why not? And I went into a little tirade on evidence-based practice and said, okay, we know that evidence-based practice is three legs of a stool, right? And we tend to really focus heavily on do we have evidence that supports this idea, or that says we should be doing that? Like really high level evidence. It's just kind of rare to have that. And if we only lean on the high level evidence, that limits us so greatly. And it, I think, can stifle. I mean, it can actually support innovation, but it can stifle it as well if that's all you feel like you can do in the clinic. The other parts of the evidence-based practice, the legs, are of course what the client wants, what they need, what they're looking for. A great example is a lot of clients come my way because they're really trying to avoid something that's really invasive, or they don't want to take medications. So they're looking for something that's more conservative, more gentle. So what does the client want? That's another one. And then the other is your clinical experience. What have you seen in the clinic? What have you tried? What do you know to be true in your own experience? And this these students just had an experience of how this technique feels in their own bodies and how much open and expansive. We asked them to try and explain or describe, and things like lighter, open, expansive, more grounded. I can feel my feet differently on the floor. I can feel the arch in my foot. Just all these different words. And so they're in their minds, they're taking those ideas and they're thinking, wow, I could do this with this person. And so his response to me of, well, why not? And it wasn't rude. He wasn't being, it was very, well, why wouldn't I? And I'm like, yes, you have to sometimes experiment and try and take ideas that are related from a scientific perspective and think about how you might take that and innovate with that idea and apply it to an area where maybe there might not be any direct literature to support it, but what can you think about that would make you want to at least try it and see how it works for this person. So if we think about somebody who's had a stroke and they're coming into your clinic and working with you, and they have an issue with spasticity, we know that that's not the only thing in front of us, is this upper extremity with spasticity. We also know we've got a person who has had many, many years of living, and they might also have had a job where they're very sedentary, or maybe they had a job where they did construction or maybe roofing, and they use their body in really harsh, repetitive ways. So maybe they had carpal tunnel. Maybe they had a past rotator cuff surgery. Maybe they had great posture and they worked out all the time. Or maybe they had terrible posture and rounded shoulders and head forward. And then now you've got this spasticity too. Maybe they're a person that was really great with nutrition, or maybe they weren't. Maybe they were a Mountain Dew addict. I don't know. But what you're getting in front of you just isn't just spasticity. Also, I'm going to keep going with this. What if there were a person that had hip surgery in the past, or a broken leg, or what I'm getting at here is they might be coming to you with layers and layers and layers of fascial tension in their body from lots of just how their life accumulated, from injuries to posture to general health. And so thinking of that spasticity as not just an upper extremity issue, but a whole body issue. And so thinking of it in the way that, okay, fascial tension can be contributing and moving into that arm to create a worsening effect of that. But then I also want you to think about how the spasticity then, if we don't find a way to manage that spasticity can then travel up into the shoulder and into the neck and into the chest and into the whole body, because the fascial system is all connected. So of course these ideas got me on the internet this morning and looking to see what I could find about spasticity that might contribute to a bigger conversation. So I first found a review, a systematic review and meta-analysis, and it was in the Journal of Personalized Medicine, which I have never heard of, but it really sounds good to me. So it was a 2021 review, and it was titled the Effectiveness of Stretching in Post-Stroke Spasticity and Range of Motion, Systematic Review and Meta-Analysis. And they basically concluded, I'm going to read to you from the study. Studies involving passive static stretching used a protocol in which stretching is kept relatively short. One factor that can influence the results is the mode of application of stretching. The interventions that required a physical therapist for stretching took less time than the interventions involving self-stretching or external aid. It is possible that the interventions involving means such as long-lasting orthosis or splints to prolong the effects of stretching over time were even better than short-lived static, passive, or dynamic stretching. Okay, so something else they said was performing passive stretching periodically is extremely important, as stretching is known to reduce the spasticity of affected joints. However, it returns after some time. I think that's really good information to think about. If we think about that from a bigger picture, okay, well, we may not make long-term change, but is it still a good idea to do the short-term stretching from the perspective of the joints, from the perspective of fascia? So if I think about the science that I know and understand, I know that when you do the stretching and you open up a joint and areas of the body that you maybe haven't opened up for a while, for example, going to a yoga class and putting your arms over your head or your hips in a deep internal or external rotation, even though it's brief, you still want to do it because it helps to get nutrition into those spaces that maybe weren't getting them fully, and to bring that nutrition into the tissues, into the cells. And that can be helpful. So should we not do our yoga class because it's maybe isn't going to hold over time because of the life we lead? Well, of course, go to that class. And when you get that nutrition in there, we're much less likely to experience pain in that area or worsening of the stiffness that then can also contribute to further pain. So doing something passive can be, well, doing something to stretch yourself into those deeper areas can be really, really effective. So looping it back to the idea of this myofascial self-treatment that we do, we use these little therapy balls. If you're not familiar with it, they're little, I think they're 2-inch balls, and they're kind of, they're stiff, but they're squishy still. They're not hard. Never use lacrosse balls or hard stuff. Golf balls, no. Literature does not support that. I started teaching these self-treatment classes to the public, probably 6 or more years ago now. And after 2 or 3 years into it, I had a couple of OT students come do a rotation with me, and I asked them to do a survey with to survey the people that had come to the workshop in the past. And we got a pretty awesome return rate. I believe it was over 50%. I can't remember exactly right now. But of the people that responded, which was, we sent it out to, I don't know, maybe 300-ish people. And no, I did not write this up. This is a very informal for my own information to continue deciding whether I was going to continue what I was doing in my business or not. So the information they got back of the people that responded, over 95% of the people that responded said they were still using the techniques. And most of them said they were using it on a regular basis as part of their self-care routine. So what I know is that people love this. They love how it feels in their bodies. And when they finally get it, that gentle, consistent pressure is better than the rolling and grinding, they tend to stick with it. And we get lots of people who come back to the level 2 and the level 3 workshops that we offer to just learn how to do more with it and do it differently. Okay, so where am I going with this? So my thoughts were, okay, what happens what are some of the resulting factors when you do have spasticity? And we'll just take the upper extremity again. Well, that constant tension in there, regardless of where it comes from, that constant tension in the muscle is causing a shortening and a tightening of that muscle that can continue to worsen and worsen over time. And then what we know about fascia is fascia surrounds everything, right? It doesn't just surround that one muscle. It doesn't just surround the bicep. It surrounds every single muscle fiber in that bicep. We also know from the science that we know is that fascia responds to the pressures that we put in our body. So if it detects pressure, it's so adaptive, it's going to start thickening and tightening itself because it needs to be supplying support to all the structures that it surrounds. So if it's the message that it's getting, even if it's a dysfunctional message, then it's going to tighten around this area and get stiffer and tighter itself. And then all the fluids within it and around it are going to get stiffer and tight and stiffer as well, and less flowy, more viscous. And then what we also know about the fascia is that it's interconnected to everything else. There's no start or end to it around the bicep, that it goes down into the elbow and down into the hand, goes up into the shoulder and then into the neck and down into the rest of the body. So if we get a dysfunctional tightening of the fascia in one area of the body, that's going to pull into the surrounding areas and potentially beyond. So if you reach down and grab the bottom of the shirt that you're wearing, hopefully that's a stretchy shirt, but it doesn't matter, and just start to ball up that material. And as you ball up that material, where do you feel it pulling into? I can feel it pulling on my back, on my shoulder, even down into the sleeve. Let's say if we did the same thing and we took if you're wearing a sleeve, then ball up that material around the bicep and see how that starts to pull. I can feel the tension pulling up into my neck, around through my shoulder blade, and even a little bit down into my rib cage. So if you imagine that's what's happening in your fascial system, and the fascial system of someone who's got spasticity going on, wouldn't we want to address that and make sure that that doesn't happen? So we're not talking about just a problem in the arm. We're talking about preventing problems from other places. And I know that our healthcare system doesn't always like to do that. I think we're really slowly moving in that direction, and we don't get paid to do that. We get paid to remedy the problem in front of us. But we've got to at least provide the education that if we don't get this managed between the client and maybe the caregiver, then we might have bigger problems down the line, and we don't want that. I got back on the internet and I'm like, okay, there's got to be something out there somewhere. And yay, Carla Stecco from Italy. I've talked about her in other podcasts. And I also got to see her at the Fascia Research Conference. She's so hard for me to understand because her accent is really fun and cool to listen to, but you've got to work super hard to understand the accent and super hard to understand her information because she's so flippin' brilliant. So I found a study that was published in 2014. In 2014, peripheral mechanisms contributing to spasticity and implications for treatment. And this was published in Current Physical Medicine and Rehabilitation Reports. So I want to read to you what she writes in her conclusion. We argue that connective tissue alterations begin a vicious circle composed of three phases. 1, an increase in the viscosity of the extracellular matrix, leading to active muscle stiffness. 2, exacerbation of neurally mediated reflex mechanisms due to subclinical contractures affecting the threshold of muscle spindle activation. And 3, fibrosis due to collagen deposition and an increase in passive muscle stiffness. Fibrosis leads to further increase in the extracellular matrix viscosity, or too thick, in the surrounding areas, restarting the circle. These peripheral mechanisms contribute to abnormal postural adaptation, myofascial pain syndromes due to the dynamic response of the mechanoreceptors, localized and altered connective tissue, and further disuse and disability. And the last sentence, we provide a rationale for emerging therapies that may be helpful to restore normal connective tissue architecture and tissue gliding mechanisms. So that, again, was, 2014. So this information is out there. What we don't have is the good studies to say, okay, if we do this myofascial self-treatment or maybe myofascial technique or any other kind of prolonged stretch that targets the fascia, whether that's active or passive or done by a caregiver, done by the person, whether it uses a tool or whether it doesn't, does it help? And does it help prevent problems? And that's hard to do, right? Because I don't know who's going to do that research, who's going to do it. But if we know that is a likely potential outcome, the least we can do is educate our clients about it and try to prevent that from something that they have to experience in life, because that spreading of tension can lead to lots of pain and further dysfunction. And we absolutely want people to continue to have as much quality of life, regardless of their diagnosis or disability, and the ability to participate in those activities that are important and meaningful to them that they need or want to do. So, what's my message? Of course, my message is please learn the basic science of the fascial system so that you can think about these things in a little different way, so that you have more kind of another language to interpret the body, interpret what's happening in the body, and think in a new way, in a slightly different way about existing problems, so that you can innovate and you can try new things and maybe have that attitude of this young, soon-to-be OT of why not? If it might help, why not? Let's give it a try and see what happens. And I'll wrap up with, and that's the attitude. I know I talk about the research congress a lot, but it was just super cool. And that was totally the attitude of what was going on there. Was the researchers weren't just on stage saying, listen to what I have to say, and then I'm important and this is important, so listen. It was the researchers talking not just to other researchers, but also to the clinicians and saying, okay, clinicians, I want to hear from you. What do you think about this? And what are you experiencing out there in the world? And how can you clinicians help us shape future research? So we'll wrap with that. So what a fun day yesterday, and it always gets me thinking when I'm around students, and that's what re-energizes me. So if any other therapist out there or student wants to connect, has a question about how fascia might apply, I really jam on doing the research and trying to make those connections and draw those conclusions. So very open to being contacted. So have a wonderful day. Thank you. Thank you for tuning in to the Fascia-Informed Therapist. It's been a pleasure sharing insights and strategies to help you integrate fascia science into your practice. I'm Amy Mayer, and I hope today's episode has inspired you to explore further and take your therapeutic skills to the next level. Remember, we're committed to creating and providing top-notch, evidence-based, fascia-informed continuing education that empowers you as an occupational therapy practitioner. Stay connected with us for more enriching content, and don't forget to check out our online courses to deepen your expertise. Until next time, keep expanding your knowledge, refining your skills, and confidently applying the science of fascia to your practice. Here's to advancing together in health and wellness.